Again, we welcome you to the breakout session here at the Rural Health Association of Utah's annual conference that we've moved to a webinar format. And we'll be discussing oncology and rural health here in Utah. We have on our panel Garrett Harding from the Huntsman Cancer Institute, Dr. Haslam from Intermountain Healthcare, and Dr. Grossman from Huntsman Cancer Institute with us today to discuss how they're doing community outreach throughout Utah. We'd like to begin by thanking our sponsors, which are projected here on the screen. This has been great sponsorships throughout Utah, including Intermountain Healthcare and Huntsman Institute. We thank you for your sponsorship to get these messages out to our rural community and to look for opportunities to meet the gaps, especially with prevention, treatment, and screening for oncology throughout rural Utah. We also would like to let you know, for those that are seeking CME, that they can email Rural Health Association of Utah, RHAU@suu.edu, and request CME for the sessions that you've attended. This will also be located in the chat session. Additionally, we have Danielle, who will be monitoring questions, and we ask that you ask questions for the panels in the Q&A section, and also become engaged in the chat session with the current topic that we're discussing. With that, we'd like to have each of the individuals introduce themselves as they begin their presentation. We're going to start with Garrett Harding from Huntsman Cancer Institute, and he's going to take the screen, and then he'll pass that on to the next panelist. Thank you. Garrett.
All right. Is that working?
Yes, we can see that great. We can hear you.
Wonderful. So I want to thank you, Locke, and the others on the panel. I think this is going to be a really good opportunity to not only kind of show the burden of cancer, what's currently happening in the state of Utah, but also the different ways that we're engaged through partnerships, both through our community outreach, education, engagement, treatment, prevention, all of those things. So I'm going to try and give a kind of tee all of this up in a way that we can kind of look at some of the specific things that we're doing, both from Huntsman Cancer Institute, the University of Utah, and then in collaboration with partners like Intermountain Healthcare, others like the federally qualified health centers, others like the departments of health in the different health districts, as well as other partners like American Cancer Society. So for those that aren't as familiar with Huntsman Cancer Institute, our mission really is fourfold in terms of, from a research perspective, a clinical perspective, as well as kind of translating that research, taking that knowledge back into the community to provide education, but also prevention, screening, detection of cancer, and other things. We're guided by three principles, which are patient and community first, a united effort, and excellence in all we do. So our mothership, as we like to say, we're located here in Salt Lake City at the University of Utah campus. We have 3 community clinics in Farmington, Utah, South Jordan, Utah, as well as Sugar House, which just barely opened last fall. And then we partner with Intermountain, which I think Dr. Grossman will definitely hit on, in providing oncology treatment in a variety of other locations throughout the state. And then we have other ways that we're connecting with, all 29 counties throughout Utah. So as you can see the cancer burden here, this is the latest data that we have from the cancer registry, which shows from an incidence perspective, the 5 cancers that remain at the top of the chart. As we know, there's over 200 different types of cancer, but breast continues to be the most diagnosed cancer in the state, followed by prostate, melanoma, colorectal cancer, and lung cancer. So we're going to talk a little bit about how we're addressing some of those priority areas, as well as how we're working to reduce the mortality as well. You can see kind of on the right side of the chart, the mortality rates. Utah has very low smoking rates as well as tobacco use, but we continue to have a high lung cancer death rate which is concerning. And so a lot of the work that we're doing in relation to tobacco cessation, as well as radon, which is the second leading cause of lung cancer as well. So in terms of, as we look at disparity work, we know that in rural and frontier areas, there's definitely more late stage diagnoses across the board, higher mortality for cancer as well. We know that things related to social determinants of health or socioeconomic status, all of those things are contributing as well. And then we see different, based off of the different race, ethnicities, different populations, different communities that we have here in Utah, we see different behaviors, which may include higher tobacco use rates, lower adherence to cancer screenings, from breast cancer to prostate cancer to lung cancer and colorectal cancer and the other screenings that we have. So we have a really great community outreach and engagement team. I'm not going to focus too much on this. I know some of them are on the call. I feel very privileged to be able to share the work that all of us are doing in collaboration. And so what this looks like is really, we're going to go into a little bit into some of those strategies, but really this is the work of a united effort. So the goals of this team are really to help characterize what are our related needs in Utah, how do we implement strategic partnerships, strategic research programs, engagement approaches, how do we work with policy, and ultimately how do we support the larger mission of HCI by bringing those resources, those services back to the community being a broad term of all the different communities and populations of the state of Utah and the surrounding area. So some of these ways are through, as we're listing here, patient navigation, which is focused both on adolescents and young adults, American Indian populations, as well as Hispanic, Latino patient navigations, through community presentations, through health promotions, specifically social media. We're using a lot of those right now, since a lot of our community-based work is being put on hold due to COVID-19. So we're really looking at strategic ways that we can reach these different populations, in ways that aren't in person. We collaborate with a lot of different partners, including the American Cancer Society, Cancer Action Network, on advocacy and policy, really bringing community health screenings, participating in coalition work, and then obviously community engaged research, as well as basic science, translational, clinical trials, all of those different buckets. So I'm just going to go into two specific things related to those strategies. And I know Lynette Phillips, who manages our mobile cancer screening program, is on the call. And so I want to, publicly thank her for, really the efforts that are happening related to the cancer screening and education bus. So this is a mobile cancer screening program that we debuted last fall 2019. And this had kind of been a pipeline dream for many years of how we can bring these Huntsman Cancer Institute services, specifically related to early detection and prevention, to the different areas of our, very rural and frontier state. So currently, we are offering 3D mammography services. These are the exact same services that you would get at any of our mammography locations. Using high-tech, secure data transmission, we're able to, take this bus throughout the state of Utah, and then have our radiologists here at Huntsman, as well as the University of Utah Health, and be able to read those and be able to get a lot of, the women who have not historically maybe not received a mammogram, or they, may not have access based off of distance, or based off of socioeconomic status, or any of these other barriers that we know are actually prohibiting, or I guess barriers for women to get these screening mammograms. So that's currently what we're offering. You can see the map here of the state, which is all the different counties. Since, inception, we've now screened over, 1,000 women. I know this chart says 900 here, but we've been able to screen over 1,000 women in all of these different health districts, which we think is so great, because 50% of those women are low income, meaning they've used some of the Utah Department of Health access to the cancer screening vouchers. And so we've been able to collaborate both with the Utah Department of Health and many other clinics, federally qualified health centers, community health centers, to really make sure that these women are getting access to screening, regardless of any of those other barriers, and making sure that, you know, we're following up with the diagnostics and the treatment and other things. So short-term goals, we're really looking to expand these screening programs, potentially into skin cancer screenings. Utah has the highest rate of melanoma incidence, HPV immunizations, genetic counseling, potentially distributing FIT tests for colorectal cancer, as well as doing head and neck screenings. So all of this is kind of in the planning stages currently, but we're really hoping this can be a model of not just providing mammography services, but full on cancer prevention and screening efforts in all of these different areas. One thing that I will say is kind of looking at this chart related to mammography, Utah continually ranks among the states that have the worst adherence to mammography. And so we're really hoping that with this effort, we'll be able to look at these different small areas in a year, 2 years, 3 years from now, and be able to see that in collaboration with these other partners, we're really seeing these screening rates, rise in all of the different areas. Things that we've learned in relation to our approach is that so much of our work has to happen in close partnerships with the local providers. And so we work in collaboration with the other health systems, not necessarily in competition. So one specific example would be, Huntsman Cancer Institute does not have a freestanding location in St. George, Utah, for example. And so we know that when we go to St. George to screen women for mammography, we are referring them back to a health system that is Intermountain Healthcare, or another health system in which the patient may prefer that they have a preference to. And so our approach is not necessarily to make money, to be able to, really be competitive in that market. We're really looking at it as a public health approach in increasing cancer screening rates. And so as part of that, Utah was chosen as one of 3 states to participate in the CDC Community of Practice initiatives, which that's in collaboration with the American Cancer Society, the Utah Department of Health, and Intermountain Healthcare. And so we're really looking at how we can look at these evidence-based approaches so that we can increase breast cancer screening rates, specifically with the cancer screening bus. Intermountain Healthcare also has a new mobile mammography vehicle as well. And so we're looking specifically in partnering on events and other things with them. So another approach that we talked about was looking at our community advisory board. So when Huntsman Cancer Institute was founded, we had an external advisory board, we had an internal advisory board, but we wanted to really get feedback from the community in a very strategic way so that we could look at what are the ways that we can better serve the communities, those that have been historically disproportionately affected by cancer or impacted by cancer. So we formed a community advisory board with the goals of establishing community and personal connections, building on these long-term partnerships, developing a shared understanding of how we can work together to prevent cancer and improve cancer outcomes, and then guide the work of that team, which we shared, as well as ultimately developing those community-engaged research programs, which are really going to change the landscape of cancer through implementation science and through community engaged research. And so what we were able to do is, you can kind of see this map here, the Huntsman Cancer Institute is the only National Cancer Institute designated comprehensive cancer center in this region. And so we were able to recruit individuals from all 5 states in this area, as well as rural and frontier areas of the state of Utah. And we formed our community advisory board. And so that includes a variety of different individuals, but I will just say, it's been key to have the voice of those that are working in rural and frontier health in the state of Utah. So that includes, representatives from, some of our community health clinics, some of the business members that may be working in those different rural and frontier areas, as well as representatives from local departments of health, as well as the public health infrastructure, which we know is so crucial throughout the entire state, to be able to really form a board which we can tackle some of these challenges. And it's been really beneficial to see the participation so that we can really reach those residents that we know are in the rural areas of the state. So these are just some of the milestones and some of the things that we've worked on over the past year and a half. things related to advocacy and policy, obviously the cancer screening bus, things related to melanoma education, as well as kind of dissemination, helping with grants, proposals, and other, strengthening pipelines that are going to allow us to, have more of an impact together. The last thing that I will touch on is really the partnership that we have with Intermountain Healthcare. So Huntsman Cancer Institute, for many years, has partnered with Intermountain on what we call the Huntsman Intermountain Cancer Care Program. And so together, between both health systems, we are caring for 85% of all cancer patients in the state of Utah. So that's been a clinical approach, which the physicians here are going to talk a little bit more about. But one of the other things that we've been able to develop in the past 2.5, 3 years is working on an adolescent and young adult program from both a research perspective as well as from a patient navigation perspective, knowing that Utah remains the youngest state or among the youngest states in the United States for population. How can we ultimately increase access to different resources where you fall into the category of, I'm not really a child to be treated at primary children's, and I'm not really an adult or a senior, which is where we see a lot of our cancer patients falling. And so there's this gap of services. And so we've been able to, really robustly, I would say, increase our research programs, our patient navigation programs, serving a variety of different patients across the state in both health systems. And then the most recent thing that has come out of this is what we're calling the Utah Cancer Outcomes Outreach and Policy Cooperative, or the Utah Co-op, where there has been a $10 million initial funding investment where we are looking at what we call the Utah Grand Challenges. And so these are seed funding awards that are supporting interinstitutional community-based research, cancer control initiatives, where we have a PI or an investigator from Intermountain Healthcare, as well as one from Huntsman Cancer Institute, and collaborating on a specific initiative that will ultimately fall into that burden of cancer. What are some of the most pressing challenges, and how can we collaborate together across the board to be able to have, a unique impact? And Dr. Grossman, has been a recipient of one of those awards. And so he'll be able to share a little bit more about that specifically. But that's a lot of the things that we're doing, at least, that we could touch on in the short amount of time. And so I don't know if there's questions currently, or if we want to be able to.
Garrett, I think what we'll do is, we'll hold on the questions, although there is one in chat that I'll ask as we transition to Dr. Grossman. If you could maybe go in and address that one question about what Utah is highest for, and that's found in the chat session. Maybe you could answer that in chat. And Dr. Grossman, I'll have you start taking control here of the screen share, and maybe you can continue to expand. And one thing I'd like to say before we transition is it's great to see the collaboration. We don't see that collaboration in other states, as I've seen with my role in the Rural Health Association and my interactions with the National Rural Health Association. And so it's great to see collaborations going across systems. So thank you.
Yeah, and I'll actually let Dr. Grossman answer that question in relation to skin cancer and the highest rate of melanoma.
I'm sorry, go ahead and say that again. Garrett?
Am I coming through?
Yes, Dr. Grossman, we hear you.
Great. And what do you all see on your screen? For some reason, I've got Garrett's slides still.
I see you.
Okay, give me one moment. See if I can navigate this. Why does it not want to? There we go. I'm getting there. Okay, are you seeing something that says improving cancer care delivery?
Not yet.
Here it comes.
How about now? Do you see something that says improving cancer care delivery to rural areas?
We are, yes.
Terrific. Well, first of all, thank you for the invitation to talk. To give you some background about me, I'm a clinician scientist. I've been doing advanced melanoma practice for probably now 10 years. So I see patients both at the Huntsman Cancer Institute and at Intermountain. And sort of the new project that I'm working on is trying to build a statewide program in melanoma. And I think many of the things that Garrett hit on earlier are part and parcel to really improving things for melanoma patients in Utah. So it's hard to talk about cancer without talking about COVID right now, but I just want to bring up this one slide that I think a lot of you have seen. This is the COVID projections from the Institute for Health Metrics and Evaluation, presently being used for most of the national models, and they forecast about 60,000 deaths from this. Sadly, cancer is about 10 times as deadly still, even if you imagine COVID being in an optimistic way. So we really have to deal with this problem in a serious way, and it unfortunately will not go away despite COVID. Melanoma for Utah is important. It is the deadliest form of skin cancer. It's the third most common malignancy diagnosed in Utah. We have an annual average of a little over 800 cases. This is what we saw between 2011 and 2013. That case number is quite a bit higher based on some preliminary data I've been able to collect now, looking at both the Intermountain and Huntsman systems, probably a little closer to 1,000. The good news is most early stage melanoma can be treated with surgery, but those with thicker primaries have a higher risk of recurrence, and certainly the patients that I see have unfortunately had distant organ metastases or local regional disease, and they're still difficult to treat. Utah has a high incidence, and looking at our national averages, there's about 21 melanomas diagnosed per 100,000 population. Australia sets the record for incidence, in part because they live so close to the thinner parts of the ozone in the world. So in the Southern Hemisphere, you'll get a lot more sun exposure per hour being outside than you would otherwise. But in Utah, we live at elevation. And in many ways, that's our own version of having a thinner ozone. By going up in altitude, the sun exposure goes up pretty dramatically, and it's reflected in our incidence. We kind of bounce back and forth between #1 and #2 for incidence, trading places with Hawaii, it seems like every other year. And again, in comparison to COVID, it's still an important problem per 100,000. So it gives you some kind of ballpark figures to think about. So the program that we envision, we want to cure melanoma across the state at the highest rate possible. And to do this, we need better prevention strategies, we need better early detection, and we need optimal disease management in every location it can be given. This involves dermatology, surgery, medical oncology, and radiation oncology. Fortunately, we've had a relatively cohesive collaboration with Intermountain for a number of years, and are now making this stronger with the kind of more formal approaches. If you look at all the different locations that we can now reach, green dots represent Intermountain locations, which extend all the way north to south. Blue represents Huntsman. Red represents U of U dermatology. So geographically, we do have a reach that goes clear up to Idaho, out to Nevada, north of Carson City, and even into Jackson, Wyoming. So we do span the geography well. And I bring up this point just because we're living in an environment where we've had to invent very quickly a number of things, some of which I think are going to, in the long run, really improve things for rural care. I share you with this. Obviously, geography is a challenge for our cancer patients in these networks. And an urban patient can expect maybe a 30-minute commute. Just doing some math, a patient that I see commonly is a person with stage 3 melanoma, meaning that they've had melanoma spread from their skin to a lymph node. And to treat that patient with adjuvant therapy requires about 18 visits over the arc of the year. Each triangle here represents a doctor's visit or an infusion or a scan or something like that. So that urban patient living close by could expect about 18 hours of driving over the course of that year, getting back and forth to appointments and infusions. But for the rural patient, the magnitude is about 10-fold higher, or even worse in some cases. I did have a patient from Montana driving 10 hours to see me for every one of these infusions one year. So being able to deliver care to more outlying areas has been a challenge for us, and something that we've wanted to improve. Something that IHC has really led the way on are video and phone visits. And having practiced at both sites, they were already well into their rollout of video care for oncology patients. And Dr. Haslam may talk more about this, but we had already started our training and rollout at IHC for this before it became really a necessity. On the positive side, these cut drive time for our patients, and certainly the patients are more comfortable in their home seeing me. I've always joked that the blood pressure of my cancer patients is always about 10 points higher because of the stress associated with a cancer visit. The not so great part of this is, I think, some of the emotional content of our visits, which is, I think, a real key part of the care that I can provide a patient, is lost, even with a good video connection. We still have to do labs and infusions and other care that the patient may have to travel for. And not every patient has internet access. And we're discovering in this quick rollout of remote care how frequently that actually is a problem. Many of my visits are conducted by phone only because the patients don't have a smartphone or a laptop or something like that that we can connect to by video. Another key area from a systems point of view is CMS is paying about 10 cents on the dollar for the same amount of work as is required to take care of these patients in a meaningful way. So we need to evolve payment models that will allow more of these remote visits to be successful without bankrupting the very medical systems that are needed to give the care. So how do we decrease patient trips? There's a variety of things. One that evolved very quickly in the last couple of weeks in response to Pembro was an extended infusion schedule of the drug, rather in response to COVID, was an extended infusion schedule with one of our drugs. By being able to shift this from an every 3-week infusion schedule to an every 6, we've cut down the travel time for our patients and more importantly, have limited the number of touches they have to make to the health system, which protects both them and the system at large. This work being done through the NCCN, on which I serve as a panel member. So part of this was done quickly. Input from IHC was key in all of this too, and some of the very early calculations on the number of patient touches per clinic visit, I was able to draw from some of the work that IHC did in all of this. And then the second thing I would say, in addition to extending those infusion intervals and doctor visit intervals, is to develop newer technologies to simplify patient monitoring. And this is the thing I had planned to cover almost entirely for this because it is the subject of our Utah Grand Challenge grant. Again, that mechanism Garrett mentioned earlier, a generous gift from IHC has allowed Huntsman and Intermountain to collaborate in unique areas that may help rural Utah. So the project that we're launching is based upon some new technology developed by a company called Natera. And what's done here is a patient's primary tumor, this would be like the tumor removed from their skin, is completely sequenced. And then that whole genome is subtracted from the patient's germline DNA to generate examples of where the patient's tumor is different genetically from what they were born with. Those variants are then designed into a blood type test that can be run serially, and a patient then could, for example, have this test done prior to a therapy or a surgery or something like that, and then watch the levels of that genetic signature drop over time. And furthermore, if they have had a successful surgery like that, getting them serially monitored with their blood to detect an early relapse is a part of that technology as well. And this would give us better lead times on being able to treat advanced disease, and also be much more convenient for the rural patient, because a blood test we could do anywhere, but CT scans are not necessarily available in every location in Utah. So this is a technology that we greatly, that we'd like to see evolved. So our study design, which is led with my IHC co-investigator, Tanya Bowles, we're gonna take this biomarker and look at the levels of that ctDNA in patients with lower stage melanomas, and examine those levels before and after surgery to see whether the levels go down. This pilot could then be expanded to do more of the monitoring work I described, with blood draws being done instead of CT scans at some day. We're budgeted for about 30 patients, and we'll be collecting samples at both Huntsman and Intermountain, and those samples are being run at Natera. The study design is quite straightforward. Through screening processes, we'll collect information such as their demographics, history, blood and stool. You might wonder why we're collecting stool, but it turns out to be a very important prognostic indicator in terms of microbiome and how well the patient does. So to try and level set our population, we wanted to know exactly what their microbiome looks like. And then they'll get their surgery, and then after that surgery, they'll get more blood and stool collections and questionnaires. So this is the more or less the methodology involved. As I described earlier, they have the 16 patient tumor-specific mutations. That process is still proprietary. The informatics involved to generate those 16 DNA is what's unique to Natera. And that gives a very high degree of sensitivity in other cancers for detecting tumor remotely, and we expect this to be true in melanoma. So these are our study timelines. This project I've been working on now for almost a year. The research funding announcement came back out July last year, and we received our good news late this last year, 2019. We're now through with an IRB reviewable protocol, and we're hopeful to get our accrual going sometime in September. The pandemic has sped things back just a little bit in terms of our timelines, and I'm hopeful that we're returning more to our operating procedures by September, August. So this is how we've had to adjust our timelines for the current environment. So thank you all for your attention. And again, thanks both Huntsman and Intermountain for coming together to give me the opportunity to kind of build out this program across the state. The collaboration has been absolutely terrific and a lot of fun. So I'll take any questions.
Thanks very much. Ken, we're not seeing any questions come in right now. Dr. Haslam, I'll have you start to take control of the screen, and we'll see if any direct questions come in.
All right, can you see that okay?
We can, thank you. We'll turn it to Dr. Haslam. Thank you, and be sure and introduce yourself. Thank you.
Okay, great. My name is Derek Haslam. I'm a medical oncologist like Dr. Grossman as well. In fact, we trained together a long time ago. Time was better to my hair, I think, than his. Nevertheless, we remain good friends, and it's just so nice to see in a forum like this to be able to see that, hey, everybody's on the same page. We all want to do better things to prevent cancer, to treat cancer, and to make it so it's as convenient as possible for everybody. We really want to capture that, and I think that you're seeing that really well outlined today. I wanted to spend a moment today. Again, I'm very appreciative of this opportunity to talk about our tele-oncology program that we have at Intermountain and some of the things that we've done as of late to bring cancer care closer to home. As everyone knows, our Intermountain's tagline is helping people live the healthiest lives possible. Well, we have a belief within our cancer program that cancer is never convenient, but the care should be. And I harken back to the story. I was actually born in the Uinta Basin out in Vernal, and had an uncle that recently passed away from gastric cancer. And the nearest place he could get treatment was there in Provo. So, as many of you know, it's a 2.5 to 3 hour trip from Vernal to Provo. And they estimate in his last 6 months, they spent 36. They made 36 trips into Provo to get care. He got excellent care there. And they decided they needed to start packing an overnight bag, because they were never sure if they were going to have to stay the night, because of an infusion or imaging or whatever it needed to be. And that hit me pretty hard, because we have the technology and the ability now to be able to provide that care close to home. And, the thought that the last 6 months of life were spent on the road, nauseated, not feeling well, made me feel like that we just really need to do something differently and rethink this. We know that when we look at cancer patients and when you survey cancer patients, they're concerned about 3 specific things. Number one, they want to make sure they're getting the latest and greatest in cancer care. They want to make sure that what's being done is the same thing they would be getting at any facility anywhere. They also want to make sure they're getting supported, both the patient and the caregivers that are around them. They want to make sure that this is navigating cancer is really difficult. It's a very complex system, and they want to make sure that nothing's being dropped within the cracks. They want to make sure that somebody's there to hold their hand the whole way. And the number three thing that patients want is they want convenience. They want to be able to spend the time that they have around family, friends, and loved ones in the places that they love to enjoy and visit. And we really believe that this technology we have available through tele-oncology or telehealth, these telehealth portals that we have, can provide that. We also know that there have been so many advances, and Ken touched on a couple of these things, but so many advances lately in the delivery of cancer care that it becomes very, very possible for patients to get 90 to 95% of their cancer care close to home. Now, there are certain surgeries and procedures and radiation treatments and specialized treatments that need to be done in a bigger facility where they see larger volumes. But by far and away, many of the infusions, oral medications, targeted therapies, immunotherapies can be delivered in an infusion center that's in someone's hometown, if done the right way and partnered correctly. So we've been able to provide this world-class cancer care and been with regards to leveraging a whole system-wide expertise that we have within the Intermountain system. We're able to support that using navigation services. So the same nurse navigation system that we have in our on-site facilities that help walk patients through the process of getting scans and biopsies and treatments and end of treatment discussions, that can all be done via telemedicine. Genetic counseling services can be done that as well. And through that and through the partnerships we have in those local communities, we can provide that convenience that patients desire. One of the things that we really wanted to make sure and emphasize when we started this program is we wanted to make sure the experience that somebody was having if they lived in a more rural location was the same experience they'd be having in another. I was very skeptical of this. As Kim mentioned, one of the things that I enjoy being an oncologist is you do make a very emotional connection with people. And I thought that there was no way I was going to be able to deliver that same sort of compassionate care to my patients if I'm, hundreds of miles away from them and through a video screen. It turns out that if you have the right people on the other end, you have good nurses and you have good support staff on the other end, they're able to provide that reassuring touch, that arm around the shoulder that patients need. And often they would rather have it from them anyway, because it's their neighbor, it's their friend, and it's their loved one that lives down the street from them, or attends church with them, or goes to ball games with them in their own community. So I agree that there are definitely some barriers to providing the same sort of care you would get in person. It can be, there are some aspects of it though that supersede any of that and can make it so that patients have a very quality experience. In fact, when we look at our patient surveys after undergoing this tele-oncology experience they have in these other locations that we do this in, the patient experience surveys, satisfaction surveys are quite high, as high and certainly comparable with the ones we have in our on-site clinics as well. So we felt really good about that we were able to leverage these technologies and resources, these new treatments. We were able to standardize processes and flows so that the same care is being delivered no matter where we're delivering that care. And what has been really key to this is really partnering with good providers and facilities that are scattered throughout the Intermountain West. We have very, very good partnerships with them. And anytime we set up one of these tele-oncology sites, we go and have these on-site visits and really try to get to know the people there that are helping to cover for us from a distance, and that we become a resource and really an extension to them. In the results of our tele-oncology program, again, we stretch from St. George to up to, we have 2 locations in Idaho, 1 in Wyoming, and several throughout Utah. We just opened one in Nevada earlier last month, and we have a clinic going in the Uinta Basin now that has been going for about 6 months now, and it's shocking. I think when we talk about the numbers of patients who are affected by cancer, when you start to go out and turn over all the rocks, you realize that it affects a lot more people than we probably anticipated, because we are seeing a lot of patients in these rural communities that we didn't anticipate as far as projections of volumes and numbers. So we have seen many, many patients now via this teleoncology service. We've had this up going for about 5 years now. We have sites both within the Intermountain system and then also outside of the Intermountain system that we partner with to do this. We have 8 different locations scattered throughout the Intermountain West. As I mentioned previously, this high degree of patient satisfaction where they're able to get that care in their own hometown. And for the communities in and of themselves, the boon it is to those individual facilities to be able to maintain not only the infusions that are kept there within their own facility, but also the labs and what imaging can be performed there, what procedures can be performed in that facility has been really important. Especially as we see, the changes in healthcare and some of these smaller facilities being really challenged to stay open and to keep going business as usual. This provides another level of service and another level of revenue for these facilities to be able to maintain that open. It's been a really fulfilling road for us, and we continue to plan on expansion. I think that one thing about this COVID-19 pandemic that we're in is it really has accelerated the acceptance of this technology and these video visits and the ability to be able to deliver care remotely. I think that it's going to fundamentally change the way we practice medicine. I think we were crawling along at a slow pace to get there. And I think because of this virus, if there's one good thing that's going to come out from it, it's going to be that it really accelerates this ability to provide care remotely and make it really convenient for people. With that, I just end and be open for questions as well when the panel starts.
Yeah, I do have a follow-up, Dr. Haslam. We often look at the cost savings to the system and to the medical system. Have you looked at cost savings directly to the patient and getting a hotel room and travel? I would think that would be significant.
Actually, yes. In fact, we have a paper in publication right now. It just got accepted that looks at that. We took the first place we did it was actually in Sevier in Richfield. And we looked at the cost associated with the visits that these patients were making. So we looked at things like the carbon footprint and the cost of missed wages and the travel expenses of both the gas and mileage as well as the hotel stays. And it's a very significant cost savings, not only to the facility in and of itself that gets to capture those revenues, but just as you're mentioning, to the community. All that revenue stays in the community now, and with those patients, they're not having to shell out cash at every Maverick along I-15 to get their care. They just keep that at home, and it does really impact them on an individual basis as well.
Yeah, and we do know that when a family's affected by cancer, that's already a financial burden on them, and so taking some of that financial burden away is important. Dr. Grossman, there's two questions here in the Q&A for you. What is it in the blood that indicates whether or not the cancer is in remission or growing?
The Natera test is designed to basically take the patient's primary tumor and then figure out what's different about that primary tumor and the patient's own genome. And then what's actually tested in the blood is the nucleic acid or DNA that's shed from the tumor. So as you can imagine, when tumor cells are growing, they're growing fast. And in many ways, they're like, if you were, for example, to try and build a house and you built the house in such a hurry that, you threw the 2x4s up and kind of banged in some nails, it would be a relatively fragile house. And the first windstorm that blew by would kind of blow the whole thing over. Cancer cells behave a lot that same way. As they're growing fast, they're also breaking apart quickly. And the contents from inside that cell are then spilled into the bloodstream. And with the very high sensitivity tests we now have to be able to amplify different segments of DNA out of the blood, we can detect those snippets that are coming from inside the cancer cell in the bloodstream.
And then on follow-up, it was also asked about the stool samples and what can be, what are you looking for in order to, in the microbiome and the findings that indicate the condition of the patient?
So one thing we learned early on in the care of melanoma patients, this is work led by a variety of individuals. Jennifer McQuaid and Jen Wargo from MD Anderson are probably the lead investigators here. And they studied a group of patients with defining all of the microorganisms that are present in their stool. And were able to characterize different characteristics between patients, those that had a more diverse microbiome, i.e. those eating probably more vegetarian type of diets to ship them there, were doing better. They were living longer, and they were having fewer side effects related to their immune-based chemotherapies. And so that's led to further investigation to try and figure out, first of all, do we really understand down to the detail we need to what types of bacteria are beneficial, which are harmful? And then the second question becomes, can we actually shift a patient's microbiome from one that is unhealthy to one that is healthy? And that second question has a lot to do with two factors. Firstly, it's more than just taking in the right kind of bugs. You've probably seen at the grocery store these little capsules that contain probiotics, is what they're called. As it turns out, taking lots of probiotics isn't so great. It actually creates less diversity in that patient's microbiome. What we think is probably more important are the prebiotics, or rather the fuel that a person takes in. And that the best fuel you can get are lots of fruits and vegetables, undigestible fiber. All of those things that our moms always told us to eat basically turn out to be pretty good for our microbiome. And so through this study, we're hopeful to confirm some of those ideas. And I suspect that we're going to learn over time that, those people that are getting higher fiber content in their diets are going to have a more diverse microbiome and subsequently probably better outcomes from cancer.
Thank you very much. Next question's for Dr. Haslam. Have you seen certainly an increase in telemedicine visits due to COVID-19, and how could someone request that their visits, be by telemedicine with you directly as an oncologist?
So great question. Yeah, so we definitely have seen a spike up in that, and we're trying to leverage that technology even more so than we have to keep people, out of high traffic areas. So right now, the tele-oncology service at each of those locations that we have it is by referral. So a primary care physician, just like they would normally, refers to one of our oncologists that perform the tele-oncology service there at that particular site. As it relates specifically to COVID right now, what we are doing is we are going through all our schedules, and we're contacting our patients and seeing about their willingness to do the visit via video visit or phone, in order to again cut down on the traffic that comes in and out of these sites, and it's been very well accepted. We have been able to reduce the patient flow into our clinics by almost 60 to 70% in some areas. People are just more and more willing to take that on. As far as accessing the tele-oncology piece in each of those clinics that we have, that's just a referral from a primary care provider.
And generally, when you start a new patient, is that an in-person visit, or could it be a telemedicine visit to start with, followed up by telemedicine?
Yeah, so we initially thought that people would at least want to see us in person once at the first visit, and so we always give that option, but nobody ever does. They would rather not be in the car. So we do all first visits and all follow-up visits via video or via tele-oncology.
And I think this.
Yeah, and I'm a little bit newer to this, but I'll just echo some of the things Dr. Haslam mentioned. I was quite skeptical as to whether or not a telehealth visit would work well, particularly for a new patient. But being forced to do that in the last month, I've discovered that it can work quite well. And my patients definitely look more relaxed in their living room. The one thing that is still, I think, difficult is there isn't quite as complete an information exchange, I feel like, between the two platforms. There are things that I can do in a clinic visit, such as examine my patient's lymph nodes or wound healing or scars and things like that, that I'm not able to, as a provider, get quite the same comfort level with when I go remotely. But gosh, it's probably 90% of the way there. It's really pretty remarkable.
And there's a general question on how to determine if cancer is genetic or not. Dr. Grossman, maybe you could take that, and Dr. Haslam, if you have a follow-up.
Sure. I think it starts with a good family history. So in my practice, I'm always asking my patients about their family members. Did their mom or dad have cancer? Maybe an aunt or an uncle or a grandparent. At what age did they have that cancer? And typically, genetically inherited cancers tend to have clusters in families where you'll have both, mom and mom's sister having cancer, and then the same cancer affecting the patient. Beyond that, once we get a suspicion from a family history, we'll confirm that with genetic testing. And I think one remarkable thing about Utah is they have a terrific genomic database from contributions from many extended families within Utah. And through that work, we've been able to actually identify a number of the cancer-causing genes that many of you have probably heard of, BRCA1, for example, being identified from Utah families many years ago. And so we take advantage of that information. We're able to determine for sure whether or not there is an inherited cancer risk. And then from that, be able to advise family members on how they might relay that information to other relatives, and how they can actually maybe step up the type of prevention strategies that we're talking about in this conference.
Thank you. Dr. Haslam, anything to add?
No, I totally agree with that. I think that we know that about 10% of cancers are inherited, meaning that you can pass them on. I think that it'll be interesting, in the future. This is a whole different world of genetics and genomics and molecular markers. It'll be interesting. I would anticipate we'll find other genetic factors that play into this, but with the current, what we know right now of the known genes that cause cancers, about 10% of patients have hereditary cancers. And so just like Dr. Grossman said, screening those patients, taking a very good, accurate family history could mean a whole world to that family and the progeny that follows.
Yeah, genetics has really been a great thing. And I know even on the treatment side, and my daughter, who's a geneticist, has told me don't speak about it because I don't know enough about it. But one thing I do know is that you're using genetics to identify, the best course of treatment as well. And maybe we could just quickly end. We've just got about 2 more minutes here, and quickly end on that. Dr. Grossman first, and then Dr. Haslam, how you're using that.
Well, it really has transformed oncology in many ways. We use genetics not just for identifying family risk, but also to identify what a particular tumor might be vulnerable to in terms of the drugs that we use. A good example in melanoma, about half of my patients will have a new mutation in a gene called BRAF, and that genetic disturbance in the tumor can be treated with a specific drug that targets that mutation. And there are examples of that all over different tumor types now, really being broken out in the last 10 years.
Dr. Haslam?
Yeah, I would agree. And particularly melanoma and lung have led the way. It used to be in training, when you had somebody with an advanced stage melanoma, it was really, really sad. You just didn't really have anything to offer them. And I think there's a whole new world that's opened up with regards to looking at the genomic profile, the molecular profile of these tumors, and more importantly, all these new drugs that are available to help match those up and get people on treatment. So it's a lot different than it used to be, which is a really good thing.
And I think we do have a couple more questions that just came in here. Do you see any differences between rural and urban patients? Is there anything in rural primary care that's missing?
That's a really good question. So I have been really, I've been really reassured by the great quality providers we have in all these different rural sites that we visited. We got really good people who are committed to helping each other out. I think the only real drawbacks, or not necessarily drawbacks, but the really challenges in the smaller facilities is just often you don't have as much of the imaging and the lab capability. And so even sometimes when we are treating patients in a smaller community, they'll have to go in for certain tests at bigger facilities. But I have seen equal attention in both urban and rural to getting screenings, colonoscopies done, getting mammograms done. In fact, in some rural areas, it's better than some of the really high dense urban areas. And there's a lot of socioeconomic factors that go into there.
Thank you. Thank you very much. And we're just going to end with one quick question have we been able to see a variation between in-person versus telecare? Dr. Grossman, if you could just take a moment and answer that question, and then we're going to.
It's probably better for Dr. Haslam. It's very early days for me in my telecare experience. It's only about 2 weeks old. So, so far, so good.
Haslam, maybe you could take that one on any variations between in-person care versus telecare. Don't know if we have had enough time or not.
You mean as far as like outcomes are concerned?
Correct.
There doesn't appear to be any difference with regards to outcomes as far as how long somebody lives or how well they do on certain treatments. We're able to deliver those same treatments across. I mean, we'll continue to look at that, obviously, because if there is, we'll want to know about it and correct that problem for sure. But we have not seen any differences there.
Well, we want to thank each of you for your time. We actually are going to end this session. We're needing to start another one on the same network here very shortly. But Dr. Grossman, thank you. Dr. Haslam, Garrett Harding, thank you very much for your time and for the work that you're doing collaboratively across Utah. And I think other states are seeing this as well. And we hope that you stay healthy and safe in this interesting time that we're in. Thank you.
Thank you.